Hey everybody, thank you. Hey everybody, good to see everybody. This is going to be a lecture, part of the administration lecture series. Uh, you all know me. Today I want to dream a little bit together because especially this year, it's easy to focus on what's wrong with the context that we face alongside our patients. But for today, let's imagine what emergency medicine could look like if we went beyond stabilizing symptoms, but instead built healthier neighborhoods. So what we're exploring today are system ideas and designs that improve outcomes, lower costs, and shape how the emergency department functions inside of a larger ecosystem. So I want to look at evidence, models that already exist, and the power that we have as emergency physicians to influence patient outcomes. By the end, I hope that you'll see yourself not only as a clinician, but as someone who can change the system, even if it is a little bit at a time. All right, so today's objectives are to dream about what a healthy, just neighborhood really looks like, to explore evidence-based, low-cost community interventions that already work, and to reflect on your role as an emergency physician and what that could become. And finally, to act with real steps that you can take this year, next year, or soon after that are within your grasp. All right, so let's start with a quick poll, quick show of hands. Raise your hand if you've seen the same patient in the emergency department more than once in the last few months, and the root of the problem was bigger than or beyond anything that the emergency department alone could fix. Right, that's our patient population. Very often. Thank you for participating. So the reality is, we know that repeat visits aren't always about what we could have done differently with clinical care that first time. Sometimes it is, but sometimes people come back because of what happens outside of the hospital. Before and after discharge. So, that could be housing instability, that could be addiction, that could be transportation barriers, unsafe neighborhoods. And in so many emergency departments around the United States, you see low resource patients that are from low resource communities, and they're being cared for in low resource hospitals. That's very common. So wouldn't it be helpful, though, if we wondered what it would look like for a neighborhood to be healthy in ways that don't rely on high salaries or abundant resources, but instead on connection, support, infrastructure that actually works? So instead of talking about what's broken, how about we describe what we would see in a truly healthy neighborhood? So that would be in addition to, obviously, affordable healthcare options for all, but let's think beyond that. Anyone want to name some characteristics of what you would imagine to be a healthy neighborhood? Like what if the neighborhood where you live in right now was a healthy neighborhood? A grocery store? Yeah. Schools, safety, like yeah, lights, like maybe like low crime. Okay. A supportive community. Public recreation, cool. Clean streets, I like that. Yeah. Go ahead. Ramps and elevators for accessibility, fantastic. Yeah, access to healthcare. Yeah, absolutely. Access to affordable healthcare. Yeah. A record store, cool. I like that. Yeah. All right. So thank you. That was fantastic. So vinyl records, right? So you might notice affordable housing. You might notice safe parks for exercise, healthy food access. Everyone takes their medications as prescribed. Everyone trusts the emergency department and their primary care doctor. Primary care is close by to where people live. There's easy public transportation anywhere and everywhere. Everyone has good health literacy and follows discharge instructions. And in a healthy neighborhood, what about social support and accompaniment? I know some of you mentioned that as well. So in a healthy neighborhood, it's possible that social support and accompaniment can help facilitate things related to health. So everyone would either have their family or their neighbors or friends or just other local people, their neighbors supporting their health between visits, encouraging good health in a way that they understand. So To care for your health, you as a patient would not only be seeing doctors and nurses and clinics and hospitals, but everyone would have someone who lives nearby, making sure that you understand discharge instructions, helping you pick up your medications, or driving you to or accompanying you at follow-up appointments. In my mind, those would be some characteristics of a neighborhood that supports health. So you might think this is beyond our grasp or idealistic, but the proof of concept is there, is here. So real trials, real dollars saved, real lives changed. So let's look at what actually works. So let's look at the evidence. All right. So when it comes to community health workers, several studies in a population of low income, high utilizer patients in a safety net system, the intervention was community health workers after discharge compared with usual care. And the outcomes were reduced hospitalizations and 250% return on investment, which is really good. All right, so here's some of the evidence. Right, so less likely to have multiple 30-day admissions. All right. So when it comes to group prenatal care, in a population of pregnant people in urban underserved settings, the intervention was group-based prenatal visits through centering pregnancy, compared with usual care of one-on-one prenatal care, and the outcomes were reduced preterm births and reduced NICU stays. Lower risk of preterm birth, lower risk of low birth weight, and lower risk of NICU, as I mentioned. And then when it comes to doula care, particularly doulas who support during labor, in a population of Medicaid and safety net pregnancies, the intervention was continuous community doula support during labor compared with standard intrapartum care without a doula. And the outcomes were reduced C-sections, increased breastfeeding, and reduced postpartum depression risk. This was a Cochrane review. Great. So these aren't just nice ideas. They're randomized control trials, they're systematic reviews, and they're real world reproducible interventions with measurable impact on costs, on health outcomes, and on human dignity. So going back to hiring community health workers for post-discharge accompaniment to reduce readmissions, why does that matter? So here's a board's pearl. Which CMS measure carries financial penalties tied to hospital readmissions? Through the hospital readmissions reduction program. Does anybody know, like, within what time frame readmissions get penalized, or like for what conditions? 30 days, excellent. And then, like, what are some of the conditions? You don't get paid for the second visit, right? So the hospital can get penalized. And then what are some of the medical conditions that this is for? It's not for every readmission, it's just for some. Heart failure, okay. DQ. Okay, I have a few here. So pneumonia, COPD, CHF, acute MI, CABG, and total total hip and knee arthroplasty, possibly DQ as well. Okay, so all right, here are some effective models. So these ideas that we've been discussing are already running in programs that you may or may not be familiar with. So community health workers across the country are embedded in accountable care organizations and federally qualified health centers. Peer recovery coaches linking emergency department patients to treatment. You see that at Kings County Hospital. In the emergency department, whenever you get some peer counselors coming in from the R building, you have RX outreach, you have Good RX, you have 340B programs that ensure that medications stay accessible. And then you have programs like Centering Pregnancy and doula programs like Ancient Song, which is here in Brooklyn. All right. And then when it comes to neighborhood facing programs that hospitals partner with to help make communities healthier, I'm thinking back to our dream of what a healthy neighborhood looks like. There's some programs that hospitals and clinics collaborate with to work on early risk detection. So Health First, which is an insurance company here, and CareMore are already generating real-time social risk scores that flag patients that are likely to fall through the cracks. There's community paramedicine and mobile teams that extend that reach, meeting people where they are. There's trusted messenger programs, whether in faith settings or local networks, that can spot trouble early, often before the health system does. And then other programs help hospitals and clinics with structural wraparound care. So this is what fills the gaps when patients leave the emergency department. So community-based organizations like CAMBA, which we work with at Downstate and Kings County Hospital. And then there's Gowanus Mutual Aid and other mutual aid organizations nearby that can stabilize food, housing, or financial needs. And then we in the emergency department, we use from the administrative standpoint in the emergency department, we use tools like Unite Us and NowPow to make emergency department social determinants of health screening actionable by closing the loop on referrals outside to the community. So we've seen effective models of putting medical services and public health messaging right where people are as well, in shelters, in food pantries, in churches, and even barbershops. So places like New York City Health and Hospitals rely on and work with these programs to bring a more relational and less transactional approach to patient needs, because health systems know that reducing unnecessary hospital visits saves money, reduces our wasted time and resources, and it's good for patients, and it clears up the waiting room. So we can build and have built prevention and resilience into the workflow to be part of everyday care, working with programs like these. And then just lastly, here are some examples of some grassroots neighborhood health models that have been already doing this. So they've been able to scale and inspire similar programs, relying heavily on community health workers, community cooperation, and local collaboration. So one of them is the Camden Coalition in Camden, New Jersey. It's just outside of Philadelphia. And they've used hotspotting, finding out where most of their repeat visitors to the emergency department are living. And they've used, they send community health workers to homes and neighborhoods of high ED utilizers and promotes a housing first approach. Then you have the Roots Community Center in Oakland. So it's community led. It combines health services with workforce development, and also is involved in outreach, advocacy, and capacity building. Next, you have Boston Medical Center and Health Leads. They were pioneers in making social determinants of health a clinical tool. So in pediatrics clinics, where it provides services, physicians can prescribe food and housing to their patients and their families, and then college student volunteers then connect those families to local resources to meet these needs, which enable them to achieve stability and opportunities that lead to better health for their children. And then finally, you have Navajo Nation Department of Health, which incorporates community governed intergenerational care, and they've had a community health representative program to promote neighborhood health since 1968. So these are proof that you can build systems around neighborhoods and not just hospitals. Finally, just want to touch a little bit on Partners in Health. It's a globally scaled example. So Partners in Health designs health systems to do a lot of neighborhood health with very little, and they help communities around the world thrive when they had not been thriving before. So their model works in Haiti, in Kazakhstan, Lesotho, Liberia, Malawi, Mexico, Navajo Nation, Peru, Rwanda, Sierra Leone, and here in the United States. So good. We've dreamed, we've seen the numbers, we've heard about real world models. Now it's time to pause and ask, where do we fit into this story? So some of us will lead programs, departments, or divisions, or we already do for some of the attendings. But don't wait for a title to start pushing for change, right? The ability to shift systems starts now in residency and as early attendings. And let me show you some broad categories of high impact roles that an emergency physician can step into. All right, so these are roles that you can step into right now, next year, or the following years. These are all relatively feasible ways that you can affect systemic change. So one way to see yourself is like a systems builder. So maybe you're drawn to QI or admin work. Maybe your superpower is turning messy discharge and referral flows into something more reliable, where patients don't slip through the cracks. Another way to see yourself is a neighborhood strategist. So you can take the emergency department insight into the community. So you listen first, then you partner with community-based organizations, community boards, local leaders to build solutions that fit the neighborhoods that we serve and make it healthier. And then finally, another thing, sorry, not finally, another thing you can do is be a policy advocate. So maybe you like writing, maybe you like public speaking or testifying with policymakers. And this is about using your voice to push for things like community health worker reimbursement or fairer resource distribution. Um, or maybe you'd rather be like a seed planner. So those of you who mentor or write curricula or design preventative protocols, you build relationships with the future generation in a way where the benefits of your work continue to ripple as time passes. So from an administrator lens, these are different ways for emergency physicians, including us gathered here, and including our future colleagues, to find like long-term gratification while we thrive or just survive in this profession. So you can start with one angle or approach that fits your strengths, and then maybe you can move between several of these roles as your career and experience advances. So since we're talking about QI, here's a quick board style question because QI does show up on the boards. Which framework is most often used to test and refine small system changes, such as piloting a new discharge workflow? Anyone? Yes. Excellent, PDSA. So the right answer is PDSA cycles. So this might be on your boards because it's practical. It's a common framework behind QI projects. So if you've done QI, chances are you've done some iteration of PDSA cycles. If you're not familiar with it, Google it later, but I'm not going to talk too much about it here. So we can wrap this up. This talk was about how we can make ripples that push system towards being healthier for everyone. You don't have to wait for a title or a fellowship to do this. And I'll mention now some low-hanging fruit, things that you can potentially do this year or next year. But I just want to say step one is always, as corny as it sounds, self-love and self-care, because joy is an act of resistance, right? Right? Uh, put your oxygen mask on before helping others, type of thing. You can't pour from an empty cup, type of thing. So that's a given. So self-love makes it possible for you to keep showing up to work every day. And every day that you put on scrubs and show up to work is already an accomplishment, and it's enough. However, when you're ready and when you're recharged, you can mentor a pre-med or medical student. One conversation can change a trajectory. You can design or improve residency curriculum modules, something that makes your program better for the next class. You can write or adapt a protocol, maybe around discharges, geriatrics, or specialty referrals, and then present or publish the outcomes. You can volunteer with groups like the Arthur Ashe Institute for Urban Health here at Downstate to build neighborhood resilience. And you can step into advocacy through EMRA, ACEP, CIR, and Partners in Health, which I mentioned has PIH Engage. And with guidance, you can publish your perspective or talk with lawmakers in local and state government and get your voice in the room. So another doable thing would be to attend a community board meeting or meet with the chairperson. So our local community board is Board 17, which helped us fight to keep Downstate open and funded. And the chair is Mr. Roderick Daly, who coaches Little League Baseball in Prospect Park, and he's open to collaborating with us. So these are things that residents have done in the past and could be a skill that maybe you didn't know you had. So consider whether any of these activities are feasible for you and interesting for you this year. We have some credibility, and in general, we're widely respected for being emergency physicians. So maybe ethically, we can think of ourselves as having a responsibility to use that power or authority to affect positive change. All right, so to recap, today we dreamed about what a healthy neighborhood could look like. We looked at evidence and models that work. We reflected on our role as a system shaper, and we planned action with small but real steps forward that will create ripples of positive change. Because if not us, then who? And if not now in 2025, then when? So maybe the role of the physician is not just to treat illness, but to insist on health. Emergency medicine is where we meet people at their worst moments, but those moments shape how we practice, pushing us to insist that our neighborhoods are designed to prevent danger and illness in the first place. And that means advocating for community health workers to walk alongside our patients when families or neighbors can't, because human to human accompaniment is less costly than readmissions, and more humane than losing people to follow up and to misunderstood discharge instructions. And some of these systems interventions could keep people from needing to see us so much, which would be good for us, right? And insisting on health means recognizing that this kind of health system strengthening work is not a distraction from our careers, but a source of meaning and sustainability in a field that can all otherwise grind us down, right? And grind people down. And maybe our calling isn't just to diagnose and resuscitate patients. Maybe it's to reimagine what is possible. Thank you.